superior part of the right atrium. And the impulse travels from the SA node through the internodal tracts to the atrioventricular node. From there, it actually passes through the bundles, the right bundle branch and the left bundle branch. And as you know, the left bundle branch again divides into the anterior and posterior vesicles. So, and the impulse travels from the SA node through the atrium to the AV node at a speed of about 0.5 meter per second. And in the AV node, there is actually a slowing of the contraction. It's about 0.05 meter per second, because the atrial contraction has to be complete before the ventricular contraction has to start. In the bundle of His after AV node, the speed is a little more like 2 meter per second. And then once it reaches the bundles, left and right bundles also it's the same. But then once it reaches the Purkinje fibers actually into the ventricles, speed is the maximum, that is 4 meter per second. But inside the ventricular mass, the impulse travels at a very slow speed. It's about 0.5 meter per second. Again, like in the atrium. So we'll come to the practical implications of this later again as we discuss the case scenarios. As we all know, there are 6 limbed leads we commonly use and 6 chest leads. That's the reason why we call it a 12-lead electrocardiogram. And the limb leads are lead 1, 2, and 3. Because you might have heard of this Einthoven's triangle, where actually the leads are placed in the right wrist, left wrist, and the left foot. And as you know, the right foot is actually a neutral lead. And between the lead on the right wrist, that's AVR, and the left wrist, it is the lead 1. Between AVR and left foot, it is the lead 2. And between left AVL and AVF, it is the lead 3. I included this slide just to remind you about the implication of these leads as far as the cardiac anatomy is concerned. So when we look at the leads, AVL, lead 1, and V5, V6, they actually correspond to the lateral aspect of the heart. That's basically it's the left side. These are all left-sided leads. So when we interpret the ECG, this will be useful for you. V1 is a right lead, and V2 and V3, as you know, are anterior leads. Lead 2, 3, and AVF, actually, they look to the bottom of the heart. That's the inferior leads. So these are the inferior leads. So when we come to the changes in the voltages in these leads, we will know the reason why we need to know about the anatomical correlation between these leads and the ECG voltages there. And it's important that you know where the leads have to be placed when you actually take an ECG. It's very important that these are made, we make sure that these leads are kept properly. As you can see here, V1 and V2, V1 is actually the 4th right intercostal space close to the sternum. V2 is the 4th left intercostal space close to the sternum. V4 corresponds to the mid-clavicular line, and V3 is between V2 and V4. V5 is the anterior axillary line, and V6 is the mid-axillary line. V3, R, and V4R correspond to the position of V3 and V4 on the left side. As you know, in children, we may have to take right-sided leads like V3R and V4R also sometimes, because the right ventricle is the predominant ventricle during early years of life, especially during infancy. So we may have to take instead, not just V1, V3R and V4R also on the right side. And I'm sure you're all familiar with this hexaxial reference system. And the hexaxial reference system actually tells you the superior and inferior and the right and left relationship of the cardiac action potentials there. you can just remember this by memorizing this particular picture. Because the person's right hand corresponds to the AVR and AVL. And the legs correspond to the leads 2 and 3. I think this is something which you can actually try to remember. So it will be very easy for you to interpret in ECG later on. And this actually tells you only the superior, inferior, and right left relationship, whereas the chest leads tells you the horizontal relationship, anteroposterior. As you can see here, if you look at the V2, it's actually exactly perpendicular to the V6 lead there. That will tell you whether the anterior forces or the posterior forces or lateral forces are more predominant. And it's very important that you are systematic in life. And in the ECG reading also, if you are systematic, you will not miss anything specific. You can actually adopt any particular order in which you read the ECG, but then it's important that you actually follow one particular order. Otherwise, you will tend to miss many things in reading ECG. And this is this is the order that I usually follow when I read an ECG. We will be discussing about all these to a little extent in the next few slides. Paper speed, standardization, the rate, rhythm. Then you remember the PQRST. You remember all the intervals and the segments. Then the QT interval, T waves, U waves, and see if there are any specific additional characteristics for the ECG and comment on that. If you follow this order always, don't just look at the QRS and tell the axis as you start reading the ECG. So you'll miss many things if you are not looking at the other things in the beginning. These are all the most basic things that I am talking about for those of you are not very much familiar with reading ECGs. As you know, this is the standard speed that we usually keep, that is 25 millimeter per second. But sometimes some ECGs come with a speed of 50 millimeter per second. It's very important to be written there on top of the ECG, the speed 25 millimeters per second or 50 millimeter per second. Because sometimes we had cases referred to us as severe bradycardia. By just looking at the ECG, the doctor has referred the child to the pediatric ICU, thinking that the child has severe bradycardia. But then when we looked at the ECG speed, it was 50 millimeter per second. So instead of a heart rate of 100 per minute, it was 50 per minute. Instead of a heart rate of 50 per minute, it was 100 per minute actually. So it's very important that you examine the patient also, and also you look at the ECG, the basics, whether the speed is 25 millimeter per second or 50 millimeters per second and all that. As you all know, the one small division corresponds to 0.04 seconds. And there is something called standardization. I'll come to that again. Standardization, what we usually follow is 1 millivolt corresponding to 10 millimeter. Maybe the next slide will discuss that. And you can, depending on the voltages, like it's very tall or very deep complexes are there, means sometimes we may have to use double or half or double standardization depending on the voltages there. Because this is what we mean by standardization. This will be there in all the ECGs. You can see the small squares there. It is 10 millimeters. So 10 millimeter corresponds to 1 millivolt in this particular ECG. So it can be, suppose there are very tall voltages, you can use half standardization, like 5 millimeter corresponding to 1 millivolt also sometimes. So this is the usual standardization that we use. And there are certain important differences between pediatric and adult ECGs. As you all know, the right ventricle is the dominant ventricle in infants. And after some time, you know, it's a lung, the right ventricle that is has to do a lot of work in the early, during the, because the pressure inside the lung is very high, and that has to come down as the infant grows up. So the right ventricular dominance is very much noticeable in newborns, and it's about 2 to 3 years that the ECG will resemble like that of an adult almost. So beyond 3 years, generally we expect the ECGs to look like adults. But till that time, that can be a right ventricular dominance that you see. There are certain important changes like T waves being inverted in V1 from about 7 days of life to 6 years in children, because, you know, at the time of birth, the T waves are upright like what we see in an adult. But after 3 or 4 days, it's usually the change from the upright T waves to the inverted T waves takes place between 4 and 6 days of life. So between 4 to 6 days of life, the upright T wave that was present at the time of birth becomes inverted. And after 7 days, it is inverted till about 6 years of life. So till 6 years of life, any child between 7 days of age to 6 years of life, we expect the T waves to be inverted in V1. If it is upright, we will consider conditions like right ventricular hypertrophy. We'll come to that again after some time. And again, it's not just in V1. T waves can be inverted in V2 and V3 also. So it is normal for children to have inverted T waves between in V1, V2, and V3. That is the right chest leads. So because of the right ventricular dominance, there can be a right axis deviation. And there will be rightward and anterior forces that are more prominent in infants because of the right ventricular dominance. So the right leads like AVR and V1, V2, and V3 also sometimes having tall R waves. And the left leads, we discussed in the beginning itself that lead 1 is actually correspond to the left upper part of the heart. So it's a lead 1 is a left lead, left precaudal leads like V5 and V6 also having deep S waves. And we talk about the so-called RS progression in adults. As you know, the R waves become progressively taller as we go from V1 to V6, V1 to V5 or V6 in adults. But that is not there in infants. Because of the RV dominance, they have tall R waves in the right leads, V1, V2. And then by the time you reach the V5 or V6, R waves are not that tall. S wave that is more predominant. Exactly opposite to what we usually see in adults. So this is the ECG of a 5-day-old infant. You can see I told you that lead 1 is actually a left-sided lead. Lead 1, you can see predominantly negative. I have marked there for your convenience that you need to only concentrate on those circles there, which I have marked. Negative, predominantly negative Qrs complex there in lead 1. And that's one thing that is to be noted. Means negative in lead 1 means what? It's actually, I told lead 1 is a left-sided lead. Predominantly negative means it's a rightward force that is there. And V1, as you can see here, the Qrs complex, R is the predominant wave there. A tall R wave is there and a short S wave. And you can see the inverted T wave also there in V1. This is an 8-month-old baby. Gradually, the Qrs complex that was negative predominantly in V1 has become positive now. That's a change that happens as the baby grows. The left ventricle is becoming a little more dominant now. But the tall R wave in V1 is persisting there. You can see that. And the inverted T wave is there, very much established in V1. This is a 6-year-old child. I told after about 3 years of age itself, the ECG will look like that of a young adult. You can see the predominant R wave in lead 1 there. And look at V1 there. R wave is not as tall as as much as the S wave. So here S wave is more prominent because the left ventricle has taken over. So left ventricle is dominant now in this 6-year-old child. These are some of the changes. We'll come to other changes as we go on to the case scenarios after some time. Again, this is one of the most basic things, like you calculate the heart rate by, maybe there are many formulae. You can use this at 1,500 divided by the RR interval, number of small divisions. That will tell you the heart rate in a minute. So when do you call the child to be having tachycardia, a heart rate that is more than what is normally expected for the child's age and physical condition? There are many conditions where you can get a very fast heart rate, very slow heart rate and all that. But then generally you can have, and when a child comes to your OP for your easy remembrance purpose, I have written those cutoff values there, like in the newborn, if it is more than 150 per minute, infant, if it is more than 120 per minute, and a child more than 100 per minute. Generally, you take it as a fast heart rate. And bradycardia, low heart rate, newborn less than 90 per minute. That number 90 is important because anything less than 90, for example, 85, 86 per minute is bradycardia for a newborn. For an infant, it's 80 per minute, and a child, it is 60 per minute. These are the cutoff marks for bradycardia. So the first thing you get is the, we discussed the standardization. We told about the voltages, whether, the speed, standardization, and then you look at the rate, we have calculated the heart rate, then you look at the rhythm. So what we are interested to know is whether the rhythm is sinus or not. By sinus rhythm, what do we mean? Whether the rhythm actually originates from the SA node or not. So for that, three things we need to look at. One is whether there is a P wave preceding each Qrs complex. That is one thing. So each Qrs complex should be preceded by a P wave. That is the most important thing. Then the P wave has to be upright in lead 1 and AVF. Why we need to talk about this is that if the SA node is the rhythm originating region, the axis of P wave. So it's important to remember that this axis is not just there for Qrs complex. Axis is there for P wave, axis is there for Qrs complex, and axis is there for T wave also. So P wave axis has to be between 0 and 90 degrees. That's what we mean by this upright P wave in leads 1 and AVF. So in a normal sinus rhythm, what we expect is the P waves must be upright in lead 1 and AVF. Each QRS is preceded by a P wave that I have already discussed. And the PR interval has to be regular. That means it needs to be constant. Like if it is variable, means what does that mean? The rhythm originating area may not be the SA node. There may be some different other foci in the right atrium itself from where rhythm is originating. So three criteria need to be met. If you need to call the rhythm to be sinus, Qrs complex preceded by P wave, a constant PR interval or a regular PR interval, and normal P wave axis. Normal P wave axis means P wave is to be upright in lead 1 and AVF. Then you look at the voltages of the P wave and also the duration of P wave so that you can comment about the atrium. If there is right atrial enlargement, you expect the P waves to be tall. So if it is more than 3 millimeter tall, 3 millimeter tall means 3 small divisions tall. So if P waves are more than 3 millimeter tall, that indicates right atrial enlargement. If the P waves are broad, that indicates a left atrial enlargement. There is a value written that is more than 0.1. More than 0.1 means what? More than 0.1 second. 0.1 second means one small division is 0.04 second. So if it is more than 2.5 divisions wide, you call it, you take it as a sign of left atrial hypertrophy. As you can see there in V1, P waves have a positive and a negative component. And if there is significant left atrial enlargement, the negative component will be very wide, like you can see positive and the negative part there. So any value that is more than 0.1 second, which means it is 2.5 divisions, you consider it to be left atrial enlargement. If both are there, that is a tall and wide P wave. P wave with an amplitude more than 3 millimeter, a duration more than 0.1 second, that indicates a biatrial enlargement. So you look at the P wave first, then you talk, next thing comes is the PR interval. As you know, PR interval actually starts from the beginning of the P wave to the beginning of the Qrs complex. And you generally measure it, you measure it in the limb leads. And if it is variable in the different limb leads, you take the longest value that you get in the limb leads. As you know, PR interval varies with two factors, the age and heart rate. So the younger the baby, the younger the child, the less will be the PR interval. The more the heart rate, again, less will be the PR interval. That means an infant will have a shorter PR interval compared to an older child or adult. So at the time of birth, it's difficult to memorize all the values, but then you can look at the lower limit there. See, can you see that it's almost 0.08 to 0.09. So maybe for practical purposes, any value that is less than 0.08 seconds means 2 divisions. You can take it as a short PR interval. And the upper value, it is not very easy to memorize like, but then practically you take it as for children, if it is more than 0.18 second, it is abnormal. Like, and for newborn, it's about 0.14, I written 0.145 seconds. So remember the lower limit is 0.08 and upper limit is 0.18. And for newborn alone, you remember this 0.14 value. As you know, in adults, we generally take 0.2 second as the upper limit of normal. So we talked about P wave. We talked about the P wave amplitude, P wave duration. We discussed about the P wave axis also. Then we talked about the PR interval. Now comes the Q waves. Q waves, what does Q wave indicate? Q waves actually are due to septal depolarization that is taking place. As you know, the septum gets depolarized by the depolarization current from left to right. So you expect these Q waves to be present in the left leads. Normally, it is present in 1, 2, 3 AVF and V5 and V6. Inferior leads also, it will be there. So 1, 2, 3 AVF, V5 and V6, which are the left-sided leads. And Q waves are absent in V1. That's very important. So if you see Q waves in V1, that is always abnormal, that you must remember. And it's not just the presence of Q waves that we are looking for. We need to look at the depth of Q wave as well as the width of Q wave. For practical purposes, I have written these values for you to remember easily: 4 millimeter and 0.04 seconds. So if it is more than 4 millimeter deep, you consider it to be abnormal. If it is more than 0.04 second wide, means more than 1 division wide, you consider it to be abnormal. So deep and wide Q waves are abnormal when they are more than 4 millimeter deep and more than 0.04 seconds. That is 1 division wide. This I have already mentioned, Q in V1 is not normal. So if you see Q in V1, that indicates for practical purposes, for your purpose in your exam, for a DNV exam, it is right ventricular hypertrophy. And QS can be there in V1 if the ventricles are inverted also. Like for example, in sinus, situs inversus, where the right ventricle is on the left side or the left side ventricle is on the right side, you may get a Q wave in V1. So if you see in a child having a suspected heart disease with a Q wave in V1, consider right ventricular hypertrophy. And you normally expect Q waves in the left-sided leads. I just told you that it's V5 and V6. Suppose there are no Q waves in V5 and V6, you consider single ventricle as a possibility. So deep Q waves, I told, definitely are abnormal if it's more than 4 millimeter deep. If deep Q waves are there in leads, in the inferior leads 2, 3 AVF and the left leads, that is lateral leads, that may indicate a left ventricular volume overload. And again, deep Q waves indicate infarction pattern. Like you might have heard of infarction pattern in adults. Infarction, like Al Kappa is one situation where you can get myocardial infarction in children. Anomalous left coronary artery from pulmonary artery. Kawasaki disease is another condition which can cause ischemia and infarction also sometimes. Myocarditis also that can be. So deep Q waves are important. We'll come to that again when we talk about the case scenarios later. So we have talked about P wave, PR interval, Q wave. Then you come to the QRS complex. So, when you are asked to read an ECG, don't straight away go to the QRS complex and talk about the QRS axis. So you need to actually look at all those things before this. We have reached QRS complex only now. So QRS complex, 4 things need to be looked at. One is the duration of the QRS complex, whether it is wide or not. That's an important thing that we are interested in. The morphology of QRS complex, there may be sometimes abnormal morphology. Again, we will come to that when we come to talk about the case scenarios. The QRS axis and the amplitude and the depth of the R waves and S waves. We'll come to that again after some time. So QRS duration actually increases with age. And this for simplicity's sake, I have written this as 0.08 second here. So more than 0.08 second means more than 2 divisions. We consider the QRS complexes to be wide. If you look at the literature in children, they mentioned 0.09 seconds as the cutoff, beyond which you consider it to be abnormal. But then it is very difficult to measure 0.09 seconds in an ECG with your eyes alone. You need a computer-generated report for that. So generally, for practical purposes, if a QRS complex width is more than 2 divisions, you consider it to be wide. Definitely abnormal if it is more than 0.1 second. So wide QRS complex, there are many conditions: right bundle branch block, left bundle branch block, pre-excitation pathways, like for example, a Wolff-Parkinson-White syndrome. You can get a wide QRS complex, cardiac arrhythmias like ventricular tachycardia, premature ventricular contractions. So if there is an intraventricular block, again, a wide QRS complex may be there. Electrolyte disturbances like hyperkalemia, quinidine, procainamide toxicity, myocardial dysfunction. There are many reasons why the child could be having a wide QRS complex. And a pacemaker, if it is a ventricular pacemaker, you may sometimes you will get a wide QRS complex. As I already mentioned, QRS duration actually increases with age. More than 0.1 second is definitely abnormal in children. For practical purposes, you just look at the ECG and see if it is more than 2 divisions wide, which means it's more than 0.08 seconds. More than 0.08 seconds, you generally take it as wide QRS complex. Then you look at the Qrs axis. The main vector of ventricular depolarization is the Qrs axis. So I think you all are familiar with this method of looking at the Qrs axis by looking at the quadrants. So I'm not going into the deeper details of the basics of ECG reading. What you actually do is I showed you the hexaxial reference system there. You draw the lead one, which is the horizontal line, and then the vertical line is the AVF. And then find out whether the QRS complexes are positive or negative in these leads and locate the quadrant of the QRS axis. Find out the lead with the equiphasic R and S, which lead in the limb leads. And the axis will be perpendicular to that lead. Sometimes equiphasic reflections may not be there in any of the limb leads. Then you look at the lead with the maximum QRS deflection, either positive or negative, in the predetermined quadrant. First, you have localized the quadrant. The left upper quadrant is the usual quadrant, but it can be right upper quadrant or any quadrant. So first you localize that and then see the equiphasic, the one with the equiphasic R and S lead, and the QRS axis will be perpendicular to that. If there is no lead with an equiphasic R and S deflection, then you look at the lead with the maximum QRS deflection, and the QRS axis will be in the direction of that particular lead. We'll come to, for want of time, I will not be going into the details of how to find out the QRS axis in this lecture. We will be focusing more on case scenarios in this lecture for your OSCE purpose. That's why I'm not going into the details. And normal QRS axis, again, it is not easy to remember all this, but then what you can look at is the lower limit. I have kept there, like, see, it is there plus 13 for all age groups. Whereas the upper age limit for a newborn, it can be as much as 30 to 180. 1 to 3 months, again, as you know, it is actually the newborn has the maximum right ventricular dominance there. The right ventricular dominance comes down as the baby grows. So 1 to 3 months, it is the upper limit is 125. 3 months to 3 years, it's 110, and it is about 120 in beyond 3 years. So I think the lower limit you can remember, and the upper limit in the newborn also you can remember. It's up to 180, and others also it's around 120. So it is not very difficult to memorize. So we looked at the QRS axis also, QRS morphology, QRS duration, QRS axis. Then comes the QRS, the amplitude of the QRS. That's the R and S phase. So low QRS amplitude can be there sometimes in conditions like a pericardial effusion or a child with myocardial dysfunction, myocarditis. And generally, this is something that a situation that we face in the pediatric ICU. Almost on a routine basis, like there will be children admitted with septic shock and myocardial dysfunction, cases of viral myocarditis may be there. But the QRS amplitude is something which will tell you that possibly there is myocardial dysfunction. So generally in limb leads, if it is more than 5 millimeter, uniformly in all limb leads, it should be there. Lead 1, 2, 3, AVR, AVL, and AVF. If it is less than 5 millimeter or less than 10 millimeter in precaudal leads, you consider this to be low amplitude QRS complex. That indicates many things, like it could be myocardial dysfunction, it could be myocarditis, it could be a pericardial effusion. Next comes the QRS morphology. There may be some abnormal pattern, like for example, RSR pattern may be there, which indicates a possible bundle branch block. An appearance that is not normal looking, like what you see sometimes in a ventricular ectopic desire complexes. Sometimes the amplitude of the QRS complex may be variable, like some of the complexes may be low voltage, then a high voltage complex comes, then a low voltage comes. We'll come to those again when we discuss the clinical scenario. So polymorphic. So each QRS complex may look different sometimes. Not very common, but then sometimes we do encounter that. So after QRS complex comes the ST segment. As you know, this actually corresponds with the plateau phase of the cardiac repolarization, cardiac cycle. So after ventricular depolarization, before repolarization of the ST segment. And ST segment, as you know, is horizontal and isoelectric for all practical purposes. You actually look at the ST segment with respect to the PR segment. PR segment is the segment that is between P wave and the QRS complex. So that is also an isoelectric line. So you see if this ST segment line is actually corresponding with the PR segment or not. So normally you expect the ST segment to be horizontal and isoelectric. And what we are interested in, especially in a situation like a sick child getting admitted in the ICU and all, is whether there is an ST elevation or depression. ST changes are there or not. Many children with myocarditis could be having ST changes, T wave changes. So elevation or depression is there or not. So in the limb leads, elevation or depression up to 1 millimeter, means one division is considered as normal. Whereas in chest leads, elevation up to 2 millimeters is considered as normal. Many people consider any depression of ST segment in chest leads to be abnormal. So elevation up to 2 millimeter can be taken as normal in chest leads. Up to 1 millimeter elevation or depression can be taken as normal in limb leads. So, you know, J point is the point where the QRS complex ends and the ST segment starts. And this particular type of depression, so-called depression, is actually not very much clinically significant. This is a J point depression. Whereas this type of depression, where the ST segment is a downward slant followed by a T wave, you know, it looks like there is a negative component also for the T wave there in the beginning. So diphasic or inverted T waves may be there. But then the downward slant of the ST segment is important. Or if it's a horizontal depression, like what you see in the next second figure there, horizontal elevation or depression. And this, if it is sustained for more than 0.08 seconds. So that means if it is sustained for more than 2 divisions, it is considered as significant. So we discussed about P wave, Q wave, P wave, PR interval, Q wave, QRS complex, ST segment, and now comes the T wave. I told you about this already, like in V1, we expect the T wave to be upright in newborn period up to about 3 days, but then it becomes inverted between 4 and 7 days of life. And after 7th day, we expect it to be negative till about 6 years of age, 6 to 8 years of age, or sometimes even it can persist in adulthood also. Like so, T waves, you expect the T waves to be inverted in a child between 7 days of life and 6 years of life. You must remember that. If it is upright, that indicates a right ventricular hypertrophy. For your purpose, any upright T wave in V1 in this age group, 7 days to 6 to 7 years, indicates right ventricular hypertrophy. As I told you, T wave also has an axis, just like P wave, just like Qrs axis. T wave also has an axis, and normal T wave axis is 0 to 90 degrees. Means it is in the left lower quadrant. You calculate the TOA axis just like you calculate the QRS axis. You locate the quadrant, see if it is positive in lead 1 and AVF. If it is positive in lead 1 and AVF, it is in the left lower quadrant. That is the 0 to 90 degrees is the axis for T wave. Left lower quadrant. So T wave axis can be abnormal if there is significant hypertrophy of the ventricles. We call it a strain pattern. The T wave axis is not between 0 and 90 degree. If it is beyond that, and if there are features of ventricular hypertrophy, you call it a strain. You might have heard of left ventricular hypertrophy with strain, right ventricular hypertrophy with strain, and all that. So you can actually measure the QRS and axis first, then the T wave axis also, then see the angle between that. Normally, the QRS T angle means the you measure the QRS axis and the T axis and see the angle between these two, and less than 90 degrees what is normal. So any QRS T angle that is more than 90 degrees abnormal. Then comes the QT interval. QT interval actually, what does that indicate? QT interval that indicates the ventricular depolarization and repolarization. You know, the T wave actually indicates the repolarization wave. So it is depolarization and repolarization. And important thing to remember is that this varies only with heart rate. So with heart rate, this QT interval can vary, except during infancy, because early infancy, sometimes the QT interval can be slightly on the higher side. That's all. So I think you need to remember these values at the upper limit of normal of 440 milliseconds or 0.44 seconds. So beyond that, we consider QT interval to be prolonged between 0.44 and 0.46 seconds or 440 to 460 milliseconds. This is considered as borderline, and beyond 460 milliseconds, beyond 0.46 seconds, QT interval is prolonged. So as this QT interval varies with heart rate, we need to correct it for a heart rate of 60. So you are correcting it using a Bassett's formula. Bassett's formula is measured QT in seconds divided by square root of RR interval in seconds. So you actually measure the QT interval, then in seconds. Then you look at the preceding RR interval also. Then you use this formula. This is called the Bassett's formula. There are different other formulas are also there, but I think for your purpose, you need to remember at least this Bassett's formula. There are normal values. We will come to the implications of this again once we start discussing the case scenarios. Then comes the RS ratio. Increased RS ratio in right chest leads right ventricular hypertrophy, and vice versa, naturally. I think I will not be going into the details again because we need to spend some time for case scenarios also. RS ratio less than 1 in V6 beyond 1 month of age indicates RVH. That's an important, easy point to remember, because any RS ratio that is less than 1 means what? If the S wave is more than R wave beyond 1 month of age, that indicates right ventricular hypertrophy beyond 1 month of age. So ventricular hypertrophy, how do you know? Changes in looking at the changes in QRS axis, QRS voltage, RS ratio, T wave axis. All these things we have already discussed. Non-specific changes also. Non-specific changes for ventricular hypertrophy, we have already discussed, like the Q wave in V1 indicating right ventricular hypertrophy. Upright T in V1 after 1 week of life, again right ventricular hypertrophy. The third one, actually deep Q waves or tall T waves in left-sided leads. For example, V5 and V6, you see deep Q waves, tall T waves. That indicates a left ventricular hypertrophy with volume overload. Can you tell one example of a left ventricular volume overload situation? It's difficult to make this interactive. That's why this ECG discussion on ECG is usually boring unless it is there's some kind of interaction with the audience. But I think it's not very easy on a Zoom platform like this. There are conditions, for example, a condition like aortic regurgitation or mitral regurgitation. When there is a left ventricular volume overload, you get deep Q waves and tall T waves. RVH, I will not be going into the details because I think we need some time for case scenarios here. So these are criteria for ventricular hypertrophy, which you can always look at in your textbooks. biventricular hypertrophy. Just I wanted to tell you just about this Qrs fractal phenomenon, which indicates a biventricular hypertrophy. So both the right and left ventricles are hypertrophied, means the commonest congenital heart disease that we encounter in children is ventricular septal defect. So ventricular septal defect is one condition where you can get left ventricular hypertrophy to begin with, but after some time that becomes a biventricular hypertrophy. So biventricular hypertrophy means what? Both R and S will be told in the mid-chest leads there. So R plus S more than 50 in infants, because it's in infants that we are more interested in, like a child with VST presence during infancy with cardiac failure and other symptoms. So in mid-precordial leads, if it is more than the R plus S, count more than 50 millimeter, it is there, means Qrs fractal phenomenon, you call it biventricular hypertrophy. So with that, we have come to the end of our basic part of this discussion, basics. Now I'll be talking about, we'll be giving you some case scenarios, and is there a scope for interaction, Ajay, in this?
They can answer in the chat box.
Yeah,
I will see the answers.
Okay. Then that will be easier, I think. It'll be otherwise it'll be very boring also. This was actually a lead to rhythm strip taken in a 9-year-old asymptomatic girl. So this child was referred with a variable heart rate notice with the pediatrician. What is this? Ajay, has anybody answered?
No, sir. Participants can put their answer in the chat box.
Yeah, okay. So this is sinus arrhythmia. So as you can see, each QRS complex is preceded by a P wave, and there is a constant PR interval also. Ideally, we should look at the P wave axis also to call it a sinus rhythm. But then this is a very common arrhythmia that we see in children. Unlike adults also can have this, but then in children, sinus arrhythmia is very prominent. Like with the inspiration, the heart rate increases. With expiration, the heart rate decreases. So the RR interval shortens when the heart rate increases. You know that. So this is a sinus arrhythmia, very common condition. It's a normal phenomenon in children. This one is a child, 12-year-old with palpitation. I always ask my students the causes of palpitation. So if somebody asks you the causes of palpitation, what will be the answer like? There are many conditions, anemia, exercise, anxiety, so many things, thyrotoxic and all we can call. But then child or a person for that matter having palpitation means that there is a change from routine. That's when somebody becomes aware of one's own heartbeat. Change means change in the heart rate, a change in the rhythm of heart, or a change in the force of contraction of the ventricles. So change in rhythm, rate, or force of contraction makes you aware of your heartbeat. So this particular child came with palpitation, 12-year-old. What do you see there in the ECG? Is there any answer?
No, sir.
No answer.
I don't know.
What do you see there?
Sinus arrhythmia.
Okay, good. You tried that. But then this, I told to call this a sinus rhythm, we need a regular PR interval also. And 1, 2, 3. The fourth complex, so you look at the fourth complex there, the QRS complex, that has come a little earlier than what we expect. All other complexes are coming, that has come a little earlier, but then one more abnormality is there. The P wave that is preceding the QRS complex is looking different. Can you see that? So that abnormal looking P wave is different. So it's very likely that this P wave, the impulse is coming not from the usual sinus node. It's coming from some other place. So this is actually an atrial ectopic. So this is an atrial ectopic. It's a different focus from where this impulse has been fired, and then a QRS complex has come earlier. And you can see a compensatory pause there for the next QRS complex to come. So early QRS with an abnormally shaped PO, it's an atrial ectopic. Does this have any hemodynamic significance? This doesn't have any hemodynamic significance. This is a normal finding that we see in children sometimes. So this we ignore unless there are other things like suppose the child is already on a drug like digoxin. So digoxin is one drug that can cause this abnormality, atrial ectopics. But then otherwise, we consider this as a normal finding. So this ectopics, atrial ectopics can be seen, but then junctional ectopics also can be there. Why do you call this an atrial ectopic or a junctional ectopic? Because the QRS complex is narrow. Suppose this is a ventricular ectopic, what do you expect? The QRS complex will be wide. So if there is an ectopic beat, and if you see the QRS complexes to be narrow like this, you can see only two divisions are there, the QRS complexes. So this is either an atrial ectopic or a junctional ectopic. So when do you call it an atrial ectopic? If there is a P wave preceding that, but a P wave that is of an abnormal morphology, like you can see in this. Can you see a junctional ectopic there? The middle one. Why do you call this a junctional ectopic? There is no preceding P wave at all for that. No, there is a QRS complex that is there, but no P wave. So this is a junctional rhythm. So junctional ectopic. So both junctional and atrial ectopics are there in this ECG. Okay, this is a different child, a 9-month-old boy. This actually happened some 10 years back in our ICU. The child was admitted with hypotensive shock the previous day. Next day we went for rounds. This was the ECG there. Can you see any abnormality there?
WPW, somebody answers.
Very good. That's
Dr. Kirtana.
Dr. Kirtana has answered WPW
Dr.
syndrome.
Ravi Shekhar.
Okay, very good. So when do you call this to be a WPW syndrome? WPW syndrome is Wolff-Parkinson-White syndrome. I've written there Wolff-Parkinson-White pattern there. You call it a pattern when the child is not symptomatic. You call it a syndrome when the child presents with a problem, like a supraventricular tachycardia, like what happened in this child. This child came in shock. Child was having a supraventricular tachycardia, SVT, which was treated and reverted back to normal rhythm. So that is WPW syndrome. So WPW pattern in the ECG, 3 criteria must be met. One is a short PR interval. I told you the lower limit of PR interval in children, 0.08 second. You take it as 0.08 second in up to 3 years. Beyond that, it is 0.09 seconds. So this was a 9-month-old child, so 0.08 seconds. So 0.08 second is the lower limit. Initial slurred pattern of the QRS complex. Can you see that? The QRS complex. That's called a delta wave. And a widened QRS complex because of this delta wave. So these 3 should be there to call it a WPW pattern. And can anybody name a congenital heart disease that is associated with the WPW pattern or syndrome? Is there any answer, Ajay? Okay, Epstein anomaly is a problem. This is an ECG of a 4-month-old girl with cyanosis. Can anybody try to read this ECG? It's already 8:30, so I think I will start reading it myself. It's actually, if you look at the P waves, you can see in lead 2, just concentrate on lead 2. Tall P waves are there. I told more than 3 millimeter tall P waves indicate right atrial hypertrophy that is there in this. Then you look at the lead V1. This is an infant, a 4-month-old child as presented with an ECG V1 lead like this. What does that indicate? Is the RV or LV that is more predominant there? We normally expect RV, that means the R waves to be predominant in V1 in an infant, but this obviously has this S wave that is more predominant. And in V6, it is actually half standardization because of the very tall R wave there. So again, that indicates a left ventricular hypertrophy. Then you look at the QRS complex axis there. QRS axis is actually, it is positive in lead 1, and in AVF it is negative. What does that mean? The QRS axis is in the left upper quadrant. That is actually a superiorly oriented QRS axis. And if you actually measure the QRS axis, it's at -30 degree. So a superiorly oriented QRS axis in a cyanotic child, for all practical purposes, for your DNB exam, it is tricuspid atresia. They ask that question. So a cyanotic heart disease, superiorly oriented QRS axis with LVH. So this cell has left ventricular hypertrophy. So these 3 should be there. So left ventricular hypertrophy. Left ventricular hypertrophy, superior QRS axis. It is tricuspid atresia. Now look at this ECG. This is a 5-year-old boy with recurrent respiratory tract infections. again, cyanosis is there. I think I'll read this for you again. So the PR interval is prolonged here. May not be very clear when you look at it. Just it will take some time for you to actually find out. There is definitely RVH, because in V1 you can see almost monomorphic R waves are there, tall R waves. And look at the QRS axis again. Again, it is negative in lead 1, and AVF also it is negative. Means what? Means it is the quadrant is the right upper quadrant. Again, superiorly oriented QRS complex. And which chamber is hypertrophied? Only RV. So this is an RVH with a superiorly oriented QRS axis. So this is endocardial cushion defect for your purpose, for your exam purpose. The other one was LVH with superiorly oriented QRS axis. This is RVH, or sometimes you may get a biventricular hypertrophy also in endocardial cushion defect. So if it is superiorly oriented QRS axis with right ventricular hypertrophy or biventricular hypertrophy, that indicates an endocardial cushion defect. The child with superior QRS axis cyanotic with RVH or BVH, it is AV canal defect. With LVH superior QRS axis, it is tricuspid atresia. There are other conditions also where you can get a superior QRS axis, like sometimes inlet or multiple muscular VSD, you can get a superior QRS axis sometimes, LTJ and single ventricular other conditions. I think for your exam purpose, you need to remember the first two cyanotic heart disease with superiorly oriented QRS axis. Just remember these two. This one, a 3-year-old child was admitted with shock again. It is, I think, rather obvious, like very fast heart rate. Can you see the P waves anywhere? P waves are there, but then look at V2 there. There are P waves actually following the QRS complex there, not normal, no, obviously. So this is actually a narrow complex tachycardia. I'm sure many of you have already done PALS course, and they teach this. This is part of the PALS course always. Narrow complex tachycardia could be a supraventricular tachycardia. So you look at the heart rate, if it is very fast, like more than 220 in an infant or more than 180 in an older child. And then you look at the P waves. The P waves are either absent or abnormal in supraventricular tachycardia. Because one of the differential diagnosis for a fast narrow complex heart rate is a sinus tachycardia. So whether this is a sinus tachycardia or a supraventricular tachycardia is what we are bothered about. So we consider supraventricular tachycardia if the heart rate is very fast. That means more than 220 in an infant or more than 180 in an older child. And then you look at the P waves. If P waves are present preceding QRS, sinus tachycardia is more likely. But then if the P waves are absent, or if the P waves are abnormal morphology or abnormal position, like what we see in this P waves following the QRS complex. So that indicates possible supraventricular tachycardia. And you can see there is no variability of heart rate at all, because RR interval is remaining constant throughout life. So again, that's a point in favor of supraventricular tachycardia. Again, I think you need to look at the history also, like if there is a predisposing factor like fever, bleeding, pain, and all that, it is more likely to be sinus tachycardia. Whereas there is no specific history, a vague history, like the child is poor activity, poor feeding, excessive sleepiness, and all that, means you consider more in favor of supraventricular tachycardia. I think you can actually you will get this information again when you do your PALS course, I think. And this mechanism, I'm not going into the details now about supraventricular tachycardia. You can read up. Another child, a 10-month-old, this child is on with digoxin. Digoxin is there. Can you see any abnormality? I can't see the answer box here, Ajay. There are no answers. So you look at the P waves, look at the PR interval also. What happens to the P wave, PR interval? PR interval actually gets prolonged as you go from one complex to the other. And then finally, there is a P wave that is not conducted. What is it? The second degree AV block. We call it the Mobitz type 1 Wenckebach phenomenon. So progressive prolongation of the PR interval with the P wave not getting conducted after that. This can be a normal phenomenon again, but then you need to consider other problems like in a sick child, myocarditis, cardiomyopathy, drugs. And this indicates a block at the level of the AV node. This one, Another type of second degree AV block, where again, not all POAs are conducted here. It's actually 2:1 block. See, only alternate POAs are conducted. This indicates actually a more severe form of second degree AV block compared to the previous one. So actually the level of block here is the bundle of his 2:1 second degree AV block. Again, same causes can be there. And you need to decide whether a treatment is indicated or not, depending on the heart rate and other symptoms. This one, an asymptomatic boy, 12-year-old. What do you see there? Again, the same principles apply here. See if the POA is there preceding each Qrs complex. See if the POAs are of same morphology. See if the POA axis, if lead 1 and AVF are there, you can look at that, there or not. What you see here is a prolonged PR interval. That's all. This is the first degree AV block. First degree AV block can be normal in children, but other conditions can be associated, like endocardial cushion defect, ASD, Epstein anomaly, rheumatic fever. You know that prolonged PR interval, myocarditis, surgery, drugs. This one, another 12-year-old with palpitation. What do you see there? It's actually, there's a variable RR interval there. Very fast heart rate because of the P waves, the flutter waves. We call it the flutter waves. So sawtooth appearance. So a variable ventricular response. Not all P waves are conducted there. So atrial rate is very fast, 300 per minute. Conditions like congenital heart disease, myocarditis, post-surgery drugs. But then newborns, it is fairly common, like not very uncommon in newborns. So this can be there. Normal newborns. Normal newborns happens means generally that disappears after some time, normally. So this is obviously tachycardia. Just look at the Qrs duration. It's a wide complex tachycardia. Wide complex tachycardia, it's a ventricular tachycardia. You take it as a ventricular tachycardia, but there are certain rare situations, supraventricular tachycardia with aberrancy, we call it. About 10% of supraventricular tachycardia can present with a wide complex tachycardia. So SVT with aberrance also can be there. Aberrancy can be also there. This is a wide complex tachycardia. So I'm not going into the details of management and all that. This one, a 3-day-old diabetic infant of diabetic mother presented with seizures, 3-day-old. There are many reasons why a baby of diabetic mother to be having seizures on 3rd day, and also cardiac failure. So what do you see there? Is there any answer, Ajay? I exceeded the time limit. I'll try to finish it fast now. So the QT interval is prolonged there. And you can see, if you look at the ST segment there, it is a prolonged ST segment. So prolonged ST segment and a prolonged QT interval, that indicates a long ST segment generally indicates a hypocalcemia, because it's actually the plateau phase of cardiac cycle there where calcium is acting. So hypocalcemia is one condition, especially in an infant of a diabetic mother, where you expect hypocalcemia as a complication. You can see the ST segment there. It's the ST segment that is prolonged. I have actually mentioned the PR segment also there, because that is a reference for your ST segment. Just to look at the ST segment, whether it is elevated or depressed, you look at the PR segment and then decide. This one, 8-year-old with syncope, I'll come to the answer. It's actually, there is it's a complete heart block. So when do you diagnose a complete heart block? If the PP interval is regular, if the RR interval is regular, but then the PR interval is varying. So variable PR interval, always look at all those. Then you can tell this is it's a total asynchrony between the POAs and the Qrs complex. So the PR interval is varying, but the PP and RR interval is regular. So this is a complete heart block. I mentioned suprahesian because the complexes are narrow. If the block is lower down, what will happen? The Qrs complex will be wider. So will you refer this child for pacemaker placement? We'll come to that again. So congenital complete heart block, neonatal lupus, most of them are associated with. Congenital heart diseases can be associated sometimes, LTGV and single ventricular polysplenia, ASD, mitochondrial disorders. Myocarditis also can be associated. So indications for pacemaker in a complete heart block is if the child is symptomatic, like CCF, for example, the rate in an infant is less than 50, or if there is a congenital heart disease and the rate is less than 70, the Qrs complex are wide, means it is a lower down block, or there are features of ventricular dysfunction. You maybe pacemaker implantation may be indicated. You may have to refer the child. This one fairly simple. Child is presented with high colored urine and facial puffiness. What is striking is the tall T waves there. So hyperkalemia, hypokalemia, all other electrolyte imbalances also. We discussed hypocalcemia are common problems. In the ICU setting, and highly non-specific changes for potassium changes for in the ECG, because sometimes very high potassium you may get a normal ECG, very low potassium again normal ECG may be there. But then if this is most of the time you will get it if the value is too low or too high, like this. This is there in all textbooks. I'm not going to the details. So this one 3-month-old girl with hypotonia and feeding difficulty. There's a large heart there. Hypotonia and feeding difficulty. Is there any answer? So if you go in the order, you will not miss anything. You look at the P wave, you look at the PR interval. So this one PR interval is very short. With the tall complexes there in the chest leads, also in the limb leads also. So this one is Pompe disease. It's a glycogen storage disease. And the classic picture is short PR interval, tall QRS voltages. And T wave changes are also there. You know, T waves can be inverted up to V3 or sometimes even V4, but not beyond that. So if V5 and V6 also T waves are inverted, means we call it a global T wave inversion. Global T wave inversion is always abnormal. So if somebody has a T wave inversion up to V6, what does that indicate? It indicates a myocardial dysfunction. We usually see that sometimes that in myocarditis or sometimes in ventricular strain and all that. But then if T waves are inverted in V5 and V6, that's always abnormal. Consider a myocardial problem. This one, a 3-month-old baby with respiratory distress. I'll go to the answer straight away, because any baby 3-month-old respiratory distress, possible CCF, especially if there is a history of suggestive of frequent episodes of anginal pain, like irritable child, crying all the time, we will consider this possibility, because the treatable condition, anomalous left coronary artery from pulmonary artery, deep and wide QAs are there in lateral chest leads. Again, T wave inversion is also there in this. STT changes are also there. But then these QAs are very important. So deep and wide QAs in lateral leads in a child 2 to 3 months of age, present with cardiac failure or extreme irritability, always consider LCAP as a possibility. You can see the deep Q waves there, lateral leads, lead 1, V5, and all, V4, V5 is there. This is a 10-month-old with respiratory distress. There are abnormal QRS complexes, actually wide. I'll come to the answer now. It's actually ventricular bigeminy. Alternatingly, there are abnormal QRS complexes. And if you can see the inverted T wave that actually follows the QRS complex. So I'll come to another example after some time. And it's actually a fusion beat is actually somewhere midway between a normal complex and a ventricular ectopic. We'll come to again the ventricular ectopic part again. So this one, 1 year, lead 1 in a 4-year-old boy with respiratory distress. What is this? P wave preceding each QRS complex and the rate is very low. So this is sinus bradycardia. We'll be discussing more about bradycardia, tachycardia, and all in your PALS course. So I'll not be going into the details. This one actually, the obstetrician detected a very low heart rate in the fetus, and when the baby was born, and then 2 months the baby was brought to us with a very a significant abnormality in the ECG. What do you see there? If this history of fetal bradycardia is there, always consider prolonged QT associated. So long QT syndrome can sometimes present with only bradycardia in the fetus in the newborn period. So prolonged QT interval, this child had a very long QT interval, 550 milliseconds. We measured it using the Wasser's formula. So this is actually frequent episode of syncope in a child. Can you see the ventricular ectopic there? I showed you the atrial ectopic and junctional ectopic narrow complex. But this is a ventricular ectopic, means the QRS complex are wide. Another thing is there is a T wave of opposite polarity that is following the QRS complex. So this is a ventricular ectopic. There's no P wave preceding also, but this is lead to that. So syncope is there in this child. So what is this? So it is not just a QT interval, not just a ventricular ectopy. The QT interval, if you measure it, is prolonged also. So prolonged QT interval can again present with ventricular ectopics as a presentation. This is a 10-year-old boy. What do you see there? Again, abnormal, bizarre looking QRS complexes are there. So these are all ventricular ectopics, wide and also followed by a inverted T wave. So what will happen to, this can happen in normal children also, ventricular ectopics. So how do you know these ventricular ectopics are significant or not? Suppose the child does exercise, what happens? Normally, if it's a normal child having occasional ventricular ectopics, that will disappear once you start doing exercise. Whereas if it is an abnormal pathology is there, means ventricular ectopics will increase in frequency. So if it increases in frequency, you need to be careful about that. And if the ventricular ectopics are of different morphology in the same lead, you can see in the same lead, different types of ventricular ectopics are there. Again, that indicates a multifocal origin of these premature ventricular contractions. Again, that is dangerous. You need to be careful. So significance is when there is an underlying heart disease. If the child is symptomatic with syncope, we discussed about the long QT syndrome, if family history of sudden death is there. And if it becomes more frequent with activity, if it is multifocal, means different morphology in the same lead. If there are associated problems like long QT interval, if two or more in succession, then that is a dangerous thing. This one, a 6-year-old child, this child was admitted in ICU some 15 years back. So a few minutes after this ECG was taken, this child had a seizure. So what is the striking abnormality that you see there? Qrs complex are narrow, but then Qrs is followed by T waves which are of some abnormal morphology there. No? T waves are alternatingly, T waves are positive and negative, positive, negative, positive, negative. So what is it? This is an abnormality called T wave alternance. Means positive, negative, T waves. This generally indicates what? This actually indicates a condition associated with long QT syndrome, long QT conditions. So this is actually, any time after this, child can have a polymorphic ventricular tachycardia following this. This was again admitted in our ICU with high fever during the dengue season. 5-year-old boy. This child had actually had dengue. But then this child had a wide complex tachycardia there. Can you see that? Wide complex tachycardia. This is ventricular tachycardia for all practical purposes. But then when this, after some time when we took this ECG, I have just that red circle there. Do you see any abnormality there? Obvious abnormality in the right chest leads. In B2 also it is there. B1, B2, that peculiar abnormality of the ST segment. There is a, again, this is a different child. You can see the abnormality in the ST segment there. This actually is Brugada syndrome. Not very common in children, but then increasingly being recognized in children because there is a lack of awareness among pediatricians regarding this syndrome. So unless you look for that, you will miss this. It's a curved type ST segment in the right chest leads. It's actually a J point. J point is the beginning of the end of the Qrs complex and the beginning of the ST segment. So J point elevation at least 2 millimeter, and that is followed by negative T wave. So this is a Brugada pattern. I think you need to recognize this Brugada pattern in any child. Generally, fever is a triggering factor in actually inducing this change in the ECG in many children. So this can be associated with dangerous ventricular arrhythmias, ventricular tachycardia, ventricular fibrillation can happen. This one, another child found unresponsive, 10-year-old. This is rather obvious, like so, totally chaotic complexes there. This is ventricular fibrillation. So if you cannot make anything out of an ECG, means very likely that this is ventricular fibrillation like this. Absent heart sounds and auscultation in this child, 5-year-old, unresponsive child. So what is it? So complexes are there, but heart sounds are absent. So this is a pulseless electrical activity. This is one of the arrest rhythms. You know, arrest rhythms can be ventricular tachycardia, fibrillation, asystole, or sometimes a pattern like this. Organized complexes, but no pulse felt. This is pulseless electrical activity. Pulseless electrical activity. This one in our ICU, again, this child was admitted 2 years back. Shock. What do you see there? You can see, if you look at the Qrs complexes, the amplitude is different in each complex there. This is actually a varying amplitude of the Qrs complex. Previously, I showed you a varying amplitude of the T wave alternance. This is called an electrical alternance. Electrical alternance in a sick child, shock. What do you consider? You consider cardiac tamponade. Cardiac tamponade, this particular child had a large pericardial effusion, pyopericardium, and this child was in shock because of that. So unless you drain that, the child will not survive. So this is electrical alternance. Very important that you recognize this pattern there. I think this is the last one. The child again admitted in our ICU with multiple episodes of seizures. And so we did a therapeutic procedure after some time. Actually, this child was diagnosed to have a particular condition. What is it? We treated it, then referred the child for this particular procedure. And this particular ECG was actually recorded after the procedure was done. Can you see any abnormality there in the ECG? Can you see any abnormal markings there? I mean, markings which are not normally seen in ECG. Those are pacemaker spikes. Actually, pacemaker spikes are followed by a P wave, then a Qrs complex. So what is it? It's an atrial pacing. Why do we call this an atrial pacing? Because the complexes are narrow there. It's an atrial pacing. This, and if you look at carefully, you can see an abnormally looking T waves with a prolonged QT interval. This particular child had a prolonged QT interval, long QT syndrome, actually presented with multiple episodes of seizures and polymorphic ventricular tachycardia. And this child was treated with atrial pacing, which is one of the treatment options for long QT syndrome. So why do they have seizures? Because of the arrhythmia. They have cerebral hypoxia and they have seizures. And this is actually an OSCE question that we made for one of the sessions. So mentioned the drug of choice for stabilization of the PSU. If the child presents with seizures and polymorphic VT, we give magnesium sulfate. You know that. So this is the same ECG, actually, prolonged QTC. Again, the same child during seizures. What is it? This is the another child, but then a similar clinical picture. This is again a wide complex tachycardia with a varying amplitude of the Qrs complexes. This is what we call a polymorphic ventricular tachycardia, otherwise called torsade pointus. Very characteristic of long QT condition, polymorphic VT. I think that's the last one. Thank you very much.
Thank you, sir. Just I allow the participants to unmute. If anybody wants to ask any doubt, they can ask doubt.
ECG, I think it takes 2 sessions to complete.
Yes, sir.
I think that's the reason why we got delayed. Like it's almost 8:50 now.
Yes, sir. I think it needs some time, and physically is the main way. I think.
Yes.
More better interaction.
Yeah.
So on behalf of IAP Kozhikode, I would like to thank Jayeshna sir for that wonderful presentation of OSCE. I think it has been very useful to everyone. And please go back today itself and start reading more about ECG. See, looking at the ECGs more, right, Nasa? So that you will have more experience and you don't lose that rhythm. So thank you, sir.
Thank you very much, Ajay. Thank you all. Good night.
Good night.